Hi there and welcome to the Art of Emergency Nursing. I am your host, Kevin McFarland, and I appreciate you listening to this episode. If you haven't yet, please make sure that you go to your podcast player of choice and hit subscribe. Subscribe to this podcast so you don't miss an episode, so you catch them all. I have a special episode for you today. Have you ever worked with one of those charge nurses that just seem to best connect with the staff? The one that really has not only the minds, but the hearts of the staff as well. The kind of charge nurse that says, if they say march, the staff say, let's go. Where I used to work, that nurse was Linda Carrielison. Linda has over 15 years of emergency nursing experience and has worked everywhere from a small community ER up to an academic trauma center. As a diehard night crew, she has lots of stories to share and lots of wisdom to share with the audience. Take a listen to this episode, and I hope you enjoy.
Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement, because we all know emergency nurses have the best stories. Now here's your host, Kevin McFarland.
Just have you start with telling people about yourself. Tell them who you are, what you do, and a little bit about your experience.
Okay. Well, I've been an emergency nurse for 15 years, and all 15 of that is in the emergency department. I started out in a smaller community hospital for about a year and a half or 2 years, and then moved to the trauma center teaching hospital, the only level one in a fairly poor state with lack of resources. And I worked there for 11 years, about 7 of that as a charge nurse. And my whole career has been at night.
Ooh, wow.
I like being on night shift. It's been the only thing I've ever done. So maybe I don't know better, but I enjoy night shift. I enjoy the teamwork and the camaraderie that's built on being a part of a team when you have more of a skeleton crew. Now I've entered a little bit different phase of emergency nursing. I've relocated to Southern California, and now I work at a magnet hospital. We are comprehensive cardiac and neuro, but we don't do trauma. We have pretty good ratios, 3-to-1 consistently.
Wow.
And of course, if you have criticals, that changes. Yeah. So I'm in California now. The state I used to live in didn't have ratios. And we have a 4-to-1 ratio for the emergency department. But my hospital, a part of like being magnet and being very patient focused, is 3-to-1, nice. Which is with the exception of if you're holding psych patients or behavioral health patients, the ratios can go up depending on the acuity of the patient, and we would have a 1-to-1 sitter. So that's the only time when the ratio would go higher, or if it's like extreme overcrowding, which I think has only happened like twice since I've been there.
So do you think the ratios have made a difference in your care? Do you think you can provide better care when you're only taking care of 3 patients?
Absolutely. I mean, I'm always like comparing and contrasting my experience at the trauma center versus my experience here. I think we did amazing things with very little resources at my past job. And I was really proud of that. And I was proud of pulling together and doing that, and amazed that we could do as much as we did with as little. And I really, as a charge nurse, I feel bad because I pushed the staff. Like, you had an empty bed, you're getting a patient. It's got to go. We got to move. There's, 50 in the lobby, trauma room's full. And now I'm at a point where I can provide a lot better care to the patients. There's a few differences. We do a lot more all-inclusive care as a nurse. We don't have ER techs who do IVs and G-spoolies like we did as my other job. So we're doing a lot more with a patient. But I really have time to. I know the standard of documentation is definitely been a challenge for me, because when you have 3 patients, they really want tight documentation. And so that's been my biggest challenge. But I love being with my patients. I get to spend more time with my patients. I get to make them more comfortable. I get to nurse them more. And I find it really enjoyable. I loved the trauma room. I loved being a part of that team. But this change has been really good for me as a nurse. I'm still an emergency room nurse. I still like the excitement and everything, and that still happens. But my focus can be different now.
That's cool.
Yeah.
How was it going from leadership back to the bedside?
It's been good. I was fortunate in my other job where I got to take patient assignments, like one shift a week at least. And I was glad that I never really left the bedside. And I was just really happy to be at the bedside doing nursing care, taking care of patients. And that was fine with me. I've kind of got myself into where I'm probably will do some relief charge and doing other positions and other roles in my department. But I don't really want to get back into meetings and looking at metrics and, focus, getting further away from the bedside. Like, I've really enjoyed that.
So how did you get into nursing? Why nursing?
Well, I was a single mom, and I'd always liked helping people. I think originally I wanted to be like L&D or postpartum or some kind of mommy nurse, because I had some very good and some very bad experiences with my pregnancy and early, being a young mom. And I actually wanted to be a lactation consultant. That's kind of weird, very far from where I am now.
Wow.
And I thought it would be,
that took a turn.
It's a very big, I still pride myself as being the advocate in the department for if you have a breastfeeding mom, like, hey, let's medicate, tell her she can nurse, let's find meds that work with her, let's provide her a pump, that kind of thing. So I still have a passion for that, but definitely went in a different direction. This job has enabled me to work full-time, support a family, and do something that I love. So it was a good spot for me as a mom.
At what point in your nursing career were you positive that you made the right decision?
I think it was pretty early on. I really, I loved nursing school. I was kind of a dork. I liked getting good grades. I liked learning things. I loved, in the time that I waited to get into a nursing program, I got my EMT, and that's kind of where I fell in love with emergency nursing or emergency medicine. I did that during some downtime while waiting, and it just seemed like a good way to get some experience. And I often tell people that EMT school taught me more about being an ER nurse than nursing school did.
That's funny.
You just think on your feet. And,
it's definitely a different world than ER nursing is a different world than nursing school, for sure.
For sure.
Tell me about a patient that changed the way you practice.
Well, I remember a patient I had back in the old building. We used to have permanent hall beds, and it was real crazy where I used to work. And she was a difficult patient, and she had multiple complaints. And I was probably about 2 years into my nursing at that point, and I kind of had a few things that I thought, few guiding principles of my practice. And one of them is that if there's multiple complaints, the patient's full of crap, right? You can't have that many things wrong with you. You're just drama. That's what I thought. So this patient, she was every time the blood pressure cuff would go off, it hurt her arm. She had all this pain in her arm, and she had the numbness, and she was short of breath, and her head hurt, and then her legs were hurting. And I was just this is all too much. There's no way, you're just full of it. That's what I was thinking. And then come to find out, this lady had a hypercoagulable disorder. She'd stopped taking her Coumadin because it was rat poison, and she had literally showered clots. So she had a clot in that arm where the blood pressure cuff was. She had a DVT. She had a PE. She had a little stroke. All this stuff was actually legit. And it was crazy to me. And I tell that story to new grads. I mean, we have to discern what's real and what's not. But people who present as pains in the butt, drama patients, or people with mental health issues, they have sickness too. They have illness too, and we can't discount them. We have to kind of keep our guard up. I mean, with large homeless populations or people with substance abuse or alcohol, they are really at high risk for having a lot of complications. And we get so jaded with taking care of these patients, we need to still keep our guard up. So that lady kind of taught me a lesson. It was kind of an extreme example, but I still remember her. I remember what room she was in. And so that kind of changed things for me a little bit.
It's funny how some of those patients just stick with us forever.
Yes. She's in room 5. I remember her.
I remember room 5.
Yeah.
Tell me about a patient who touched your heart.
A lot of patients that touch my heart. Now in my practice where I work, I have a lot of really older folks who are living very well. The life expectancy, it seems like where I used to live, in a pretty poor state with a lot of socioeconomic issues and substance abuse. It seems like I just didn't see the older people who were relatively well, who were there having an emergency. But now I have an opportunity to take care of 80-year-olds and 90-year-olds that are with it, walkie-talkie, doing well. And I just really love talking to those patients and talking with their family and learning about their life. And that's one of the things the ratio has enabled me to do, is spend a little more time. Yeah. So I can't think of anything offhand and specific, but I really like the elderly. That's crazy. I never thought I would like the elderly as much because I don't like septic moms from the nursing home so much, but I do. I mean, they're challenging, they're interesting, but I like taking care of older people and hearing their stories.
Yeah, that's kind of cool.
Relatively well.
Tell me about a time that you made a medication error.
As a charge nurse, I saw many and was involved in looking into many medication errors.
I bet.
And I do like, over the course of 15 years in nursing, I think I like how it has changed from punitive towards more understanding.
Yeah.
There's that like continuum, I can't remember what it's called. We learned about if there was intent or negligence or if it was, purely an accident. And it was a heparin drip that I had started. Another nurse it was in the trauma room. It was a medical patient in the trauma room, and another nurse, he was busy and I was busy, and I started it, and he came by and he just looked at it, and you didn't look at the order, didn't really have the information either, and just signed off on it. And there was no bad outcome with that patient that I was aware of, but it did get me on my toes to slow down. Yeah, because that's probably my biggest problem is I would just go too fast.
That'll kind of wake you up a little bit and go, oh, I better pay attention.
Yeah, a little pucker. Yeah, for sure.
Yeah, for sure. What's the best advice your mom ever gave you for nursing that applied to nursing?
I think she gave me my mom passed away when I was 11, but I remember she gave me this little framed thing with the bear on it, and it said, what did it say? There's something to love in every day. That's what it said. I thought it was really sweet. And that's something that I've kept with, and even in the worst days or with the worst patients or with the most difficult providers or whatever, there's always something good about that day. So that's kind of something I kept with me.
What's the best advice a nursing mentor ever gave you?
I think it was mostly about patient advocacy and not being afraid to stand up and sound stupid or harass a physician or bark up the tree about something, just to stand up. And that's what we're there for. I can be a little bit of a pleaser. And that was something I had to learn over the years. Not so much standing up to doctors, but kind of like bucking the system a little bit, because standing up to doctors comes pretty quickly, I think. Yeah, especially in a teaching hospital.
Yeah, absolutely. I think all ER nurses need to do that to some degree.
Yeah.
But I think sometimes I forget.
I guess it was more like as a
system too.
Yeah, but it was probably more as a charge nurse that I had those hard lessons of holding a firm line and holding patients or staff to, accountable for things. And I would just want to be a little too soft-hearted with the staff. It was probably my bigger lesson. Do
you remember a particular situation where you had to do that?
Oh, gosh. There were so many. I would supervise the techs and the nurses, and, with staff who wasn't doing well, I'd want to give them, who maybe wasn't the best fit for our department. I'd want to give them a chance. I would want to give them more time, or just like, hey, they're misunderstood. And then there was another counterpart in our team that would kind of see the other side of things and would, it would be like in our leadership meetings, Linda, what do you think? And I would be like, well, I'm really optimistic. I think we can do it. And then they'd say, hey, what does this other person think, who was a lot more discerning? And she would see a totally different perspective. And then she was almost always right. Like 3 months later, it was like, yep, you were right. And so I think I was valuable to the team in that way, because I did see the good in people and I did work with people, and I was able to gain a lot of buy-in from the staff, and we developed relationships with EMS and providers and everything. And that was really important in my role, but I wasn't really good about being heavy, which I think probably caused some resentment in the team, because it just wasn't my nature to be the heavy. And so then other people who would kind of naturally would default to the heavy. And I think that might have sucked for them.
Yeah.
So that's something I don't miss.
It's good to have a little balance, though. I think the team that you're talking about had good balance. I think we had a little bit of everything.
It sure did. Yeah. I miss that team.
Yeah. Me too. What's the worst advice a nurse ever gave you?
I think, I'm not being very specific, but I think it was probably just seeing a lot of really burnt out nurses that were pretty negative about patients, and just kind of feeling that vibe and catching it when I was a new nurse. And I think that was kind of disheartening. And I really tried over the years to not become jaded and disheartened and negative about patients. Yeah, I would have to think on that a little more. I'm not sure what the worst advice was.
What advice would you give a brand new emergency nurse?
Go, at first work for accuracy and get organized, and then try to pick up on the pace, and definitely ask for help when you need it.
Absolutely.
Use your resources. You don't have to be a hero.
Absolutely. So the next question is, it's going to be one of the last questions I always ask. It's called 3 Things. And what I'm going to ask you is 3 things an ER nurse should remember and 3 things an ER nurse should forget.
Oh my gosh. 3 things an ER nurse should remember. Well, I remember Jen Gibbs used to tell me, I don't know if we're supposed to use names on here, but one of my mentors, she said, for a trauma, you should have a lead apron, a working pen, and a fresh coat of lip gloss. Do you remember she used to say that? She trained me in trauma.
Everything you need for a trauma right there.
Everything. A good working pen, especially, and a lead apron. That's funny. That's three things I remember. But three things. I don't know. It's so there's so much out there, and it's hard to narrow it down to three things. Trust your instincts.
That's a good one.
Ask for help, and take time for yourself.
Yep.
On your off days.
Absolutely. Three things to forget.
I say forget the negativity. I don't know how to avoid the burnout. I get really frustrated a little sometimes when I have I work with new grads or nurses who have been a nurse for a year, and they're just incredibly burnt out and negative about people. And they and I guess I did read that burnout is actually higher in new nurses than it is in the people who stay the course like we have, many years in. I don't know. Things to forget. I don't know. Maybe I'll call you back and tell you that one.
Okay, that's fine.
I can't think of anything offhand.
Okay. Tell me something your coworkers may not know about you that you can share.
That I'm actually part introvert, and I on my days off often, now that my kids are older and they're in school and doing their own thing all day, I might not even talk to another person all day, and a happy day may just be going for a run and cooking and organizing my drawers. That's what I've been doing my days off. Been organizing my house. So sometimes that solitude after being so bombarded with humanity for so many days that I just really like to take time by myself and have some quiet time. It's
kind of nice.
Whereas if you've ever worked with me, I'm definitely not quiet. I'm very social. I love the social aspect of my job, but then there's that other side where I just want to read a book and have some tea.
Yeah, no, I think that I feel the same way sometimes. Sometimes I get off work and I'm just I just want to be home and be quiet and chill and not, not interact a whole lot and just be me, So.
Yeah.
Tell me about your transition from the bedside to leadership.
It was, I was pretty much a permanent relief charge for quite some time before I became regular charge. So I had already been kind of doing relief, which I think is the most fun because you're the cool babysitter. You get to make decisions and you get to, lead the team, but you don't have to have any teeth in the game. You don't have to follow up on disciplines. You don't have to have projects. And so I was really well suited for the floor aspect of the job and running the department, but I was not. And I still remember my director, who was an amazing man. He was like, Linda, you're a leader, but you're not a manager. And that was a struggle in the 7 years that I did that job, was becoming a manager and not just a leader and a grower of staff and supporter of people and that kind of thing. And so doing that was hard for me. The organization and the follow-up was a challenge. I think I had a kindred spirit who shared that in my department. Yeah. And so we kind of worked through that. We tried to work through it together. And luckily, the leadership where I worked was very smart, and they paired the team up pretty well to where we all kind of had certain attributes and what we lacked, other team members picked up. So
that's cool.
Yeah.
What's the most important value you demonstrate as a leader?
Being positive and moving forward, and trying not to dwell on the sky is falling, because literally every leadership meeting we had, it felt like the sky was falling because there were so many challenges in that role. But we, hey, we're here to do a job. We got to stay the course, and we got to stay positive. There's a lot to love in this job and in what we get to do. So I think that's probably it.
What was the most difficult decision you had to make as a leader?
Probably I think calling people for, when I wasn't sure if someone was diverting medications, but I had kind of a suspicion, but I was also, you never want to be wrong on that. And so I ended up calling the house soup and coming in and calling for a drug test for an employee that turned out was actually not diverting. But she had some life issues going on at the time that we ended up referring her to employee assistance program, that kind of thing. Other times, that was the only time when it wasn't true. All of the other times, it was definitely a factor. One of the people that was altered at work was actually, it was hard for me because I knew she had cancer previously I knew that she had a lot going on and she needed this job. And like part of me being a leader was I would always get to know the staff to a certain point. And that's why when I was doing their schedule, I would think about what they're, I would want to support them and help them. And I got a lot of buy-in from that. Anyway, so I would get a little too. My biggest challenge as a leader is I would get too attached, I think, to the staff. And so this one young lady, like I knew she'd been through cancer. I knew she needed this job, but like I knew she was altered at work. And so I had to sound the alarm on that one for, patient safety. And I remember a family member of mine said, when I would have to term somebody, he said, you didn't do this to them. They did this to them.
Absolutely.
And that was the hardest thing for me because I would really think about their kids and I would really think, oh my gosh, if you get fired from this place, who's going to hire you? And what are they going to do with their life? And it's like, it wasn't my problem.
Yeah.
And that was really hard for me with a lot of like the techs I hired. I knew they were single moms. I knew they were trying to make it work and I would identify with them and I would want to make, I would feel for them, but I had to also uphold the policies and advocate for safety and all of that. So
absolutely. What was your favorite part about being a leader?
Definitely coming into a night shift where it seemed hopeless. You would have a full trauma room and you're holding, like 70% of your beds are admits and the waiting room is bursting at the seams and wondering like how you're possibly going to make this right. And then by the end of the night, you've cleared it up and you got the 6 people back. You haven't cleared the waiting room, but you got the 6 people back and you've handled this trauma patients and you've figured out, you've got some docs to go up to triage and treat some patients up there. And so you've just like really worked with, and of course the team is the one acting out all of this. And so it was just like being able to walking in and into a total mess and fixing it up for the day shift, but by the morning.
Absolutely. I'll never forget the time that I was handing off to you and there was nobody in the trauma room when you walked through. There was nobody there. And I was bragging about it because it was, you remember, it was always a disaster when I was in charge.
Everything was fine until about 1800. And then, that was your famous word.
Totally. Yeah. It was everything was good till then. But there was nobody in the trauma room. And I remember going, look at this. Look how I'm leaving you the trauma room. This is amazing. Oh my God. And then you went and did the schedule and you went and did your pre-shift. And then you came into, I think, 7 traumas or 6 traumas. It was a lot.
Yeah, that does sound like a Kevin handoff.
That was a Kevin handoff.
Yeah.
Yeah. We had some pretty interesting handoffs back and forth.
We did.
For sure.
Yeah, definitely.
Sometimes left you a little bit of a disaster or a body.
And that's it's the nature of the beast. Who was it? One of the older nurses in the old building, she was like, it's 24-hour care. Don't worry about it. We'll figure it out.
Yeah.
I think the report, you're like, I'm sorry to get to this. It's like, it's 24-hour care. Like, we're a 24-hour operation. We're not the floor. We don't get to say no to patients or, wait for shift change or anything. We just have to keep going. And that's part of what we pride ourselves on. So
what do you think makes night shift different from day shift?
I think about this a lot because I have friends who've gone to day shift and I know there's a lot of really cool people on day shift. But it's the vibe. Maybe it's that there's a management present. Maybe it's just we get a little bit delirious at night and we are able to, we just kind of let loose a little bit with our, or the skeleton crew that we have. I don't know, but I've worked night shift for 15 years in 4 different hospitals and it's always that way. Yeah. And I think it's a combination of those factors.
Yeah. Tell me about a patient that you remember back, a patient situation that you remember back and you just have to laugh. Like if someone says, tell me a funny story from your nursing care. Oh. What's your go-to story?
Gosh, there's so many. I think it was probably, we dealt with a lot of patients who were in police custody. And we had this one guy, he was in room 32, which is a room where we do a lot of wound care and things at my old job.
Yep.
And the cop was outside the door and it's night shift. He's tired, whatever. He's sitting outside the door. The patient goes in, and I think there's like an isolation cart or a wound. There was a bunch of supplies in the room. He put a bouffant cap on, a mask, like a blue gown, and gloves. And he comes to the door, and he's trying to escape.
No.
He's made a form in the bed of like a blanket form, a person.
No.
And he comes to the door, and he's like so stupid that he can't even like open the door right. So the cop gets up and helps him open the door. This incarcerated guy who's dressed up like a doctor or someone, the cop, because we watched the video later, he opens the door for this patient. And he's like, and the patient, because he was pushing the cart, like the bedside cart, out of the room to look like he had purpose. So he left the room, pushed the cart. He went down, I think, towards the hallway by CT. He ditched the gown, he ditched the cart, and then like he ran. And I think he was like, they caught him like hiding in an elevator or something. It was very funny. And we gave that cop so much crap after that. Like, you opened the door for him, like, it's so funny. Like, a lot of the funny ones were involving people in custody. Like, we had the guy who went up through the ceiling, like moved the ceiling tiles and climbed up into the up into the overhead area. And we had to close down all those rooms because we were like, we hope he doesn't fall through. We're like, what do we do to get this guy out? And then, like, we had blocked one of the rooms. We opened up the ceiling tile there, and we're like, hey, man, you need to come down. You're not going to get out. And then he, like, sticks his legs out. We have, like, a ladder, but he's, like kicking his two little legs. He can't climb the ladder. It's just like, this is our life. This is super funny, So those were the kind of things. All you could do was laugh,
Absolutely.
Those were good ones.
That's funny. Well, those are all the questions I have for you. Any other funny,
thank you.
Any other funny stories you want to tell? Funny stories or patient stories?
I mean, we all have our weird people stories, foreign bodies and stuff like that. The snake bite guy.
The snake bite
guy.
That
was one.
Oh.
You don't remember the snake bite guy?
I remember a few snake bite guys, but I don't remember.
Well, there was the snake bite guy who, like, played with rattlesnakes.
Got bit all the time. That was the homeless guy,
Got bit all
right?
the time.
There's a homeless guy. There's two.
I know that he looked homeless. I think he had some weirdly.
So there was two, and one I think may have been before your time, and it was the guy who like raised rattlesnakes or did something with rattlesnakes, and like he got bit all the time. Tell me the story that you're telling me about, that you're talking about.
This guy was kind of like a weird tweaker guy. He had poor dentition. He was like very strange. And he would get bit by rattlesnakes all the time. He would come in and we'd have to do the crow fab, and he would want to roll the crow fab with us. And he was very proud of that. And he was very proud of the fact that he helped develop this anti-venom, and because he'd given it so many times, and that he had a really important, role in the treatment of snake bites.
That's funny.
So he would come in all the time. And we were just like, geez, oh my gosh. And one time he came in and he actually, I think he was a meth guy because they treated him with Dilaudid. I think it was only like one of Dilaudid, and he went apneic. Like he totally desatted. He was like in a room at that point. He wasn't in the trauma room anymore. And I found him like 40%, like crap, so I gave him Narcan and stuff, and I was like, I saved your life, man. It was just funny. I mean, he was opiate naive, but I think meth was his drug of choice.
Meth was his weapon of choice.
Sure it was meth.
Holy cow.
Yeah. So that guy, I didn't see him for a really, really long time. And I was like, you don't really think about it. You don't want to speak their name or anything because then they'll appear. And then one day, I think I was charged and I walked by and he was in our fast track area. And I was like, oh my gosh, how are you? And he's like, I haven't, been bitten by snakes in a long time. I stopped that. I'm helping kids. I'm doing this and that and whatever. And like, he hugged me and like I hugged him back. I was proud of him.
That's awesome.
Like, they're like, did you just hug that guy? Like, yeah, I did.
Yeah.
But a side note, in the time between the snake bites and then that time I saw him in fast track where he was there for like some respiratory or something. He got into some weird stuff where he was shoving light bulbs up his butt like people do.
Oh.
And one of them broke,
Oh.
And so then he ended up with a colostomy. And then, of course, what do you do now? You shove things into the colostomy. So that was one of his other things.
No.
So he was definitely lots of self-harm, I guess, Munchausen-y, like putting himself in a bad place. It was real interesting. But, like, I truly was happy when I saw him that time, in fast track. Like, wow, are you doing good? I haven't seen you in here. He's like, yeah, I'm helping kids.
You're like,
I don't know
God.
how much help you can offer to kids.
I don't know what to think about that.
But, those are just like the characters that, you remember all those characters that we would see, and they're frustrating, but
there's so many. I mean, there's so many names that I still remember, and people I clearly see their face, and people that we'd see all the time. And like, now I still hear about, so-and-so passed away, like, oh, wow. Huh. Yeah. So. Yeah. That's crazy. It's funny how these patients leave little they plant little seeds in your mind and they just never go away.
They do, yeah. Yeah.
So you used to do the schedule all the time. What's the key to a good nursing schedule?
I mean, I really just, like I said before, I really knew the staff. And I knew like who had like games on Wednesday nights and who had like something every Friday. And, you know, like, you can't work Fridays, but I'm going to need you to work Saturdays now, you know? And so you kind of like, it's a lot of negotiation, and it's a lot of like, if you're able to meet their needs most of the time, when you have to have them do something they don't prefer, they're going to be a lot more willing, and they're going to have a better attitude about it. And so unless they were lying to me, I really think that the staff was pretty happy with me when I did the schedule for many years. And I took a lot of pride in making it balanced and trying to meet the needs of the staff so that they can have that time with their families and to do things they like. So with a lot of communication. And I had to be fair and consistent. And sometimes, you know, as a leader, it was often worse, you know, because I came up as a staff member, and I came up as someone who was very social and had a lot of friends. And I pretty much, for the most part, I would make friends with the high performers. And it would almost be worse to be my friend, you know, than not my friend, because if you're my friend, you're probably a high performer and you're going to get the crappy assignment. Yeah. This isn't scheduling, but this is just like, hey, you know, triage is horrible. I need you there. Yeah. You know,
it's a shit show out there. Go have a good time.
Yeah. Yeah. And like, that's how it is now as a staff member, going from leadership to staff. Like, I'm that nurse now, like, hey, whatever you need. Hey, it's cool. I don't mind. What do you know, what can I do to help? And that's kind of cool to just be able to be someone that they can plug in on the other side of things.
One of the things I always appreciated about you is that you were always, you know, no matter how bad it was and no matter what a disaster I left you at the end of the shift, you always had a good attitude. You were always like, it's fine. We'll get through it. We only got 12 hours.
Yeah.
So.
Yeah, it's only 12 hours of our life. That's what
right.
I always say. And it's like, I know that it's going to get better, you know?
Yeah.
And I really don't know how we made it through without really worse things happening. Like, you know, very, very bad outcomes. And I mean, we haven't even touched on, I've been talking about patients a lot and bad outcomes with patients, but that staff wasn't harmed more, you know, with violence and that kind of thing, which is, of course, a hot topic in our department, our field.
Absolutely.
Yeah. Absolutely.
What do you think? What's some advice you would give to a new nurse to avoid violence, patient violence?
Well, you got to keep your guard up. You got to watch for signs of the patient is, you know, starting to be aggressive.
Like what?
You know, like clenched fists, or they start posturing, or their body. You got to read their body language. You look for target glances. If they're going to find an object to get you to throw it at you, you know, just assess your patients. I think if you're paying attention, you're going to see those signs. You need to know when to back off from a patient. You don't need to win with a patient. You don't need to be right. And I used to see that a lot of staff, and I've fallen victim to it too, of like letting it get personal. You know, you don't need to win that argument. You don't need to assert your dominance. You do need to draw lines. You have boundaries, but you're not going to win. And of course, having an exit plan in the room. Don't get trapped in a room with the patient. You know, thinking about the way you're using your body and that kind of thing.
Absolutely.
And definitely knowing when to bow out when it's personal. It's okay. You know.
Absolutely.
Because they will get you in a person. You know, they will insult you. They will threaten your children. They will do anything, you know, and they're just trying to get you. So.
And they get so targeted. Like, they look for your weakness. They're like, you know,
they totally do.
If you're heavy, they'll call you heavy. If you're thin, they'll call you. You know, they'll find something.
Yeah, definitely.
Just to try to get to you.
Yeah, they're good at that.
Yep. What was your when you did interviews as a leader? What was your go-to interview question? Your favorite interview question?
I liked to ask them about the one where you asked them about a time where they made the wrong decision and what they did to fix it, or how they handled it. Because if they're being honest, or it's just very telling how they're going to answer that question. You know, if they show some humility, if they show some ability to learn from change, and if they can be honest enough about making mistakes. Yeah. Because it's not in, you know, I tell new grads, this is not a matter of when you make a mistake. If you make a mistake, it's when, and how do you handle it, you know? So that's a question I like a lot. And I've made a few bad hires, and I can think back to the interviews, and they'll really show you who they are in the interview. I do believe that. And sometimes, as kind of the Pollyanna of the group, I would look past that, and then I would later on see it. Like, There was this tech that I interviewed with another charge from Days, and she was a staffing tech, and she was taking a break or something. She was working that shift. It was like 10 in the morning. I came in 10 in the morning to interview this person, and maybe it was even earlier, but like she was just sitting in the lunchroom like before the interview, and he was like, why is she taking a break now? Like it's crazy out there, and it's 10, and why is she taking a big long break? And that was telling. Like I should have paid attention to that. Because she was like excessive with her breaks for the whole time. Yeah, they had her. I didn't pay attention. Staff or candidates will tell you things about themselves in that interview, and if you watch them, you can catch them.
Yeah, and it's one of those. I think Mike used to say, if someone tells you who they are, believe it.
That's true. Yeah. Mike had a lot of good pearls of wisdom.
Yeah, he had a lot of little sound bites, I'm sure.
Yeah.
Awesome.
All right, friend. Well, just let me know if you need anything else.
I will. Thank you so much. I appreciate it.
No problem. I'll talk to you later.
I'll talk to you soon. Bye-bye.
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.